Hello everyone, hope you're all doing good. In this video, we are going to discuss about hirsutism and virilization. See, this is one of the important topic as this symptom or sign when seen in the women has to be leading due to many of the pathological conditions that can be present, from minor conditions till major conditions like carcinoma. So, how to differentiate between hirsutism, virilization, and what are the investigations you have to do, and what are the management options you can give her for her psychological stability is also important. Repeating once again. So, this is one of the important chapter because most of the women will be presenting with this minor symptom, and sometimes it cannot be due to any minor pathology. It can be due to major pathologies like even carcinoma. Okay, and you have to know what is hirsutism, what is virilization. You have to give her psychiatric support also and the management options as well. Okay. So, what is hirsutism first? That is presence of prominent facial and body hair that is caused due to excessive androgens. Okay, but definitely it is not due to increase in the number of hair follicles. Okay, there is excessive androgens that you should know. And then there is change in character of the hair. Okay, so from the villous hair there is conversion to terminal hair as well. Clear? Right. Now, we will see what is virilization. So, virilization is a state of extreme hyperandrogenism that can occur due to any tumor or congenital adrenal hyperplasia or drugs. Okay. So, what are the causes? Repeating. So, what are the features of virilization? This will include hirsutism as one of the character. Then it can be associated with acne, amenorrhea, androgenic alopecia. There will be deepening of voice, increased muscle mass, and clitoromegaly as well. Okay. So, the length will be more than 10 millimeter and diameter will be more than 7 millimeter at proximity of the clitoris when there is clitoromegaly. Clear? Right. Now, let me speak about the body hair types because I know you would be confused about what is villous hair, what is terminal hair and all. Right. So, when we talk about villous hair, this is nothing but the fine hair that is covering most of the body. Okay. And then we will see what is terminal hair. It is the dark and thick hair that is present in certain parts of the body. And finally, we have the sexual hair as well. So, this hair type is sensitive to androgens and they are mostly seen in chin, back, thighs, arms, axilla, pubic area as well as the chest. Clear? Right. Now, let us see about androgens because we have seen that there is a difference in androgen levels in hirsutism and virilization. So, when androgens are going to be within normal levels, they are going to promote the growth of sexual hair alone. Okay. When they are present in excessive levels, Repeating once again. When they are present in higher levels, then they will do two things. Number one, they will convert villous hair to terminal hair. Okay. Then you have the terminal hair converted to villous hair. So, the first category is when the female appears to have a mustache, and the second category is one when there is balding of the scalp. Clear? Right. Let us see how these androgens are going to work and how they are produced. Okay. So, androgens are generally produced from cholesterol, which will be converted into pregnenolone, and pregnenolone will be converted by 17 alpha hydroxysteroid dehydrogenase into 17 hydroxy pregnenolone, and this is going to be acted upon by 1720 lyase to form dehydroxy epiandrosterone, which will be converted into androstenedione. Androstenedione is acted upon by 17 beta reductase to get converted into testosterone, which will be converted by aromatase into estradiol. Okay. Sometimes androstenedione can be directly converted into estrone with aromatase enzyme. Also remember that this testosterone is going to be converted into dehydrotestosterone by the enzyme 5 alpha reductase. Clear? So, this is how the various hormones are produced. Okay. So, you are getting androgen and estrogen as well. And remember, this dihydrotestosterone is produced 80% by adrenal glands, okay, and 20% are produced by ovary. Clear? Right. Also know that testosterone is 80% of the times, Also remember, among testosterone, 80% of it is going to be bound by sex hormone binding globulin, and dihydroepiandrostenedione and androstenedione are going to be bound to albumin. Okay. So, among testosterones, testosterone and dihydroxytestosterone are going to be the potent androgens, whereas dihydroxyepiandrostenedione and androstenedione are going to be the weak androgens. Clear? Right. See, normally both adrenal glands and ovaries are going to contribute to the production of testosterone, but in hirsutism and virilization, major contribution of testosterone is going to be ovaries, right? That point you have to understand. So, when we take hyperandrogenism, it can be due to increased production of androgens. So, the pathology can be in the ovary or adrenal glands. Then it can be due to exogenous administration of androgens, which can be any medications. Okay. Then there is increased proportion of unbound androgens as well. This can be due to decrease in sex hormone binding globulin levels. And then you can have peripheral disorders of androgen metabolism. So, there is an increase in 5-alpha reductase level. Another cause of hyperandrogenism is abnormalities in androgen receptors. So, here you have an increase in androgen receptors in the hair follicles, or else there is increased sensitivity of hair follicles to androgens. Clear? Now we will see the various ovarian and adrenal causes that are going to lead to this condition. Okay. So, we will see the ovarian causes first, which can include polycystic ovarian syndrome, stromal hypertrichosis, or the luteoma of pregnancy, tumors as well. Tumors of ovary include Sertoli Leydig cell tumors, gynandroblastomas, and then lipoid cell tumors. Clear? Next we will see the adrenal causes. Adrenal causes may include conditions like congenital adrenal hyperplasia, then any tumors or adenomas, carcinomas, even Cushing syndrome. Clear? Right. Let us also discuss about the drugs causing hirsutism. So, drugs causing hirsutism include testosterone, anabolic steroids, danazol, metoclopramide, repeating, metoclopramide, phenothiazines, progestogens, reserpine, and methyl-dopa. Clear? Yes. Now, we have a scoring system for hirsutism. Usually the quantification is done by a system called as Ferryman-Galway scoring system. Now we have a modified version of this that is going to include 9 body parts. Okay? That has to be examined for growth of hair. Okay? So, this include the upper lip, chin, chest, upper and lower abdomen, that is 4 and 5, and 6 and 7 include upper and lower back, and then you will have the thighs as well as the upper arm. So, these are the 9 regions you have to examine for characterization of hirsutism. Okay? Then in the system, the scoring is usually given from 0 to 4. 0 means you have no hirsutism, whereas 4 means you have severe hirsutism. And also remember, the total maximum score given for this scoring system is 36, and hirsutism is accordingly classified to the score into mild, moderate and severe types. So, mild hirsutism is when the score is between 8 to 15. Moderate hirsutism is when the score is between 16 to 25, and severe hirsutism is when the score is above or equal to 25. Clear? Right. Now, what are the investigations you need to do? Investigations should include initial screening. Okay. So, you have to do initial screening to exclude the life-threatening conditions first. You have to go for serum testosterone assay. Normal serum testosterone levels are between 20 to 80 nanogram per deciliter, and then you have to go for DHEA steroid, dihydroepiandrosterone sulfate assay as well. Here the normal range is between 100 to 350 microgram per deciliter, and you also go for 17-hydroxyprogesterone levels as well, usually the morning levels. Okay. When you check this, the 17-hydroxyprogesterone levels can lie less than 200 nanogram per deciliter, that means it is going to be normal. Suppose when they are between 200 to 800 nanogram per deciliter, you have to do ACTH stimulation test, and with the ACTH stimulation test again you are getting the values of 17-hydroxyprogesterone to be less than 1000 nanogram per deciliter, then that patient can be considered as a heterozygous carrier of 21 hydroxylase deficiency. Okay. Suppose when the values are more than 1000 nanogram per deciliter, then the patient can be a case of late onset congenital adrenal hyperplasia or a 21 hydroxylase deficiency patient. Clear? And what if the values are more than 800 nanogram per deciliter? You can confirm enzyme deficiency when this is present. Clear? Right. Now, apart from these investigations, you have to rule out other causes also. For that, you have to do thyroid stimulating hormone, especially if alopecia is present. Then you have to do prolactin, insulin, as well as follicle stimulating hormone and luteinizing hormone as well. Okay. Obviously, we will be doing sonography imaging also, right? So, for imaging, we will be doing sonography of pelvis, and if needed we can even do CT and MRI of pelvis. Now, let us come to the most important part, that is management. So, management involves two sections. One, you have to counsel the patient, then you are going to offer her some therapies as well. Okay. So, what should counseling include? So, when you talk about counseling for a hirsutism patient, you have to discuss about her psychological aspect, how will be the response to therapy, okay, that should be individualized. Then, what can be the duration of therapy? How about the chance of recurrence and her future fertility outcome and long-term effects of hyperandrogenism like type 2 diabetes mellitus, hyperlipidemia and even cardiovascular system defects or disorders. Right? repeating and cardiovascular system disorders, right? Now we'll see the therapy part. Therapy can be given in two ways, okay. One, you can give a pharmacological mode of treatment, and then you can even go for a physical method of management, okay. Let's discuss about the pharmacological methods first. So, pharmacological methods may include, number one, anti-androgens, which may include spironolactone, cyproterone acetate, repeating again, cyproterone acetate, flutamide or finasteride. Topical applications include eflornithine, hydrochloride cream. And most important of the pharmacological treatment is hormone suppression. So, hormone suppression can be done with drugs like oral contraceptive pills, dexamethasone, or gonadotropin releasing hormone, bromocriptine, ketoconazole, insulin sensitizing agents, okay, like metformin or troglitazone. Clear? And apart from this, you also have physical methods of management also, that includes shaving, plucking, waxing, electrolysis or laser hair removal, and then chemical depilatories. Clear? So, this is all about hirsutism and virilization. You have to know the difference, you have to know the scoring system, you have to know the causes of this, how to proceed with the investigations as well as the management. So, with this we will be completing this topic. Until we meet in the next topic, keep going, happy learning and take care.